Good morning, everybody, and to those on the other side of the planet, good evening, or indeed it could be good early morning. Welcome to this University's 21 Health Sciences Group Nursing and Midwifery Group webinar entitled Working with COVID-19 Policy and Services Responses. In a moment, I'm be delighted to have Dr. Julia Slark from the University of Auckland, who's our current Nursing and Midwifery Group Chair, say a few words. I'm your host for the webinar, and my two colleagues. Next slide, please. Karina, my two colleagues will be co-presenting. Just a few. That's Dr. Deirdre O'Donnell and Dr. Aoife de Bruin. And just before we begin, I just like to remind everybody of the housekeeping rules. First of all, questions can be asked live during the webinar using the Q&A tool. The chat function will be open for the audience to communicate with each other. For the best viewing experience, you should set your Zoom to speaker view, not gallery view. And the webinar is streamed live on the University's 21 Health Sciences Group Facebook page, and the webinar recording will be available on the University's 21 Health Sciences Group website. The tweeting about today's webinar, you may use the hashtag U21 Nursing 2020. Next slide, please. So again, just to remind you that there's three speakers. We won't give you a detailed biography, but I'm the Dean of Nursing and Head of School at the UCD School of Nursing, Midwifery and Health Systems. Dr. Deirdre O'Donnell, my colleague, is Assistant Professor of Health Systems at my school, and Dr. Aoife de Bruin is Assistant Professor and also an Ad Astra Fellow at UCD Centre for Research, Education and Innovation in Health Systems at my school as well. So thank you both to Deirdre and Aoife for your contribution to this webinar. So now I'm going to introduce, have Dr. Julia Slark from University of Auckland say a few words by way of introduction. Thank you, Julia.
Tēnā koutou, tēnā koutou, tēnā koutou katoa. Ko Julia Slark taku ingoa. Kia ora and welcome. My name is Julia Slark and I'm the head of the School of Nursing at the University of Auckland in New Zealand. And I'm the chair of the U21 Nursing and Midwifery Discipline Group. We are part of the U21 Health Sciences Group, which was established in the year 2000. The group was created to provide U21 staff and students with a framework for exploring opportunities for global collaboration in research, information exchange, and the sharing of resources across the health sector. In order to celebrate 2020, the year of the nurse and midwife, the Nursing and Midwifery Group decided to develop and host a three-part webinar series titled Professional Nursing and Midwifery, Past, Present and Future. As you can imagine, COVID-19 has rather consumed our attention, so all three webinars have focused on our response to the pandemic, and we would like to acknowledge all those who have contributed to the global response to COVID-19. This is the third and final webinar of the series, and we are very excited to present our webinar today, which is entitled Working with COVID-19 Policy and Service Responses. It is now my great pleasure to hand over to our host, Professor Gerard Feely from University College Dublin. Tēnā koutou, tēnā koutou, tēnā koutou katoa. Over to you, Gerard.
Julia, thank you very much for your kind introduction and for your nice words. So we'll commence the webinar with my presentation, which is entitled Constructing Older People's Identities During COVID-19. Next slide, please. In my paper, I will address three main themes. Firstly, I will present some recent literature reporting ageism in discourses around older adults and COVID-19. Secondly, I will outline the health system response to COVID-19 in Ireland with reference to nursing homes. And thirdly, I will ask whether the health system response may have betrayed a latent ageism in the case of older nursing home residents. Next slide, please. There is a substantial published evidence of ageing and ageist discourses associated with the global pandemic, including some evidence of ageist discourses associated with residential care. In a review of a sample of global media discourses on COVID-19 and older people, Ayalon et al. Point to evidence of public discourse associated across many countries that portray older people as being helpless, frail, and unable to contribute to society, and concluded that, quote, with the pandemic, there has been a parallel outbreak of ageism. Next slide, please. In an analysis of official statements and debates about managing the pandemic in Australia, the UK, and the United States, Liechtenstein identified ageism in the ways that public discourse depicted older adults as a special class for coronavirus control, infantilizing them for their vulnerability to COVID-19. The author instanced public age-centric debates around scarce medical resources, overwhelmed hospital systems, and highlighted a rhetoric of disposability and blame for an age cohort that was depicted as having enriched itself at the expense of the well-being of future generations. Next slide, please. The use of arbitrary cut-off criteria around social restrictions, along with misattributing risk to aging, has inadvertently reinforced and intensified negative age stereotypes. The Irish Centre for Social Gerontology raised concerns at the harmful outcome for older people that might result from strategies and discourses related to controlling and treating the virus, including the risk that treatments and resource allocation, particularly intensive care resources, could be based on an age threshold calculus and not on clinical need. Next slide, please, Karina. Fraser et al. Draw attention to the way that official public health advice in treating older adults to stay at home and cocoon implied that the coronavirus was only a risk to older people, and in this way created an us and them discourse. Vervacek and Meisner write that the COVID-19 pandemic appears to have created the right conditions for patronizing sentiments and helping behaviors targeted at older people. This wholesale positioning of all older people as vulnerable goes unchallenged, despite the evidence that chronological age alone is not a reliable indicator of medical outcome. Next slide, please, Karina. In a discourse analysis of how newspaper media in the United States portrayed the coronavirus outbreak in residential care, Allen and Ayalon showed how residents' voices were excluded and their experiences replaced by the family members, and with experiences rarely reported as a primary account from the resident, him or herself. And this analysis also demonstrated how reportage presented residential care as a dangerous place for older people and argued that such discourses constructed an overwhelmingly negative cultural model of residential care that will likely lead to mistrust of the industry. Next slide, please. So now I want to briefly summarise the health system response in Ireland as it pertains to residential care. In Ireland, the first confirmed case of COVID-19 occurred in the community on the 29th of February 2020. Like many European countries, Ireland experienced the greatest impact of the first wave of the global pandemic on its intensive care services and in nursing homes. The first clusters of COVID-19 in nursing homes were reported on the 16th of March, and the initial health system response was aimed at increasing intensive care capacity, securing effective and efficient testing and contact tracing capacity, and procuring personal protective equipment. Next slide, please, Karina. While local public health departments proactively and reactively engaged with nursing homes in February and early March, the level of preparedness on the part of nursing homes themselves seems to have been a factor in the early clusters. This was related to insufficient local governance and management structures, inadequate staff training, and physical design. The policy to manage surge capacity in the hospitals included the guidance that patients could be transferred to a nursing home, quote, before the 14 days have elapsed since the date of onset of symptoms or the date of the first positive test, end quote, but should be placed in isolation for the 14-day isolation period on arrival in the nursing home. This was presented as a necessary risk in the overall context of managing the pandemic. Interim guidelines to nursing homes advise that, quote, in general, residents with or without a COVID-19 diagnosis should be managed in their facilities unless transfer to hospital will confer additional benefit, end quote. The epidemiological evidence at the time when outbreaks began in nursing homes indicated that visitors to nursing homes were not the source of clusters. Rather, it appears that significant factors were the transfers of patients from the acute hospitals and virus transmission via asymptomatic care staff, where community transmission was already building. And next slide, please, Karina. By mid-July, when the first wave had receded, some 79% of all notified deaths from COVID-19 disease had occurred in those aged 75 years and older, with deaths in nursing homes representing a little over half of the total deaths in Ireland. One nursing home reported 35 deaths, 2 others reported deaths in the high 20s, and a further reported deaths exceeding 20 residents. The report of an expert panel on nursing homes concluded, quote, "The very infectious nature of COVID-19 makes it difficult to prevent and control in residential care settings. People in nursing homes were disproportionately likely to contract it compared to their peer age group. And the mortality rates seen in nursing homes were also higher. This is in the context of a more medically vulnerable and frail population," end quote. Next slide, please, Karina. The expert panel noted the absence of the voices of residents and families themselves from the planning process and heard reports from nursing home representatives of abandonment, a lack of support, and a sense of powerlessness and loneliness in the face of the unfolding crisis. One contributor to the expert panel declared, "The COVID crisis has shown that care is not valued in Irish society. The pandemic has laid bare the weaknesses in the provision of home care and nursing home and the lack of integration between both sectors," end quote. Next slide, please. In a report of the impact of the pandemic in the residential care sector, the Irish Health Information and Quality Authority concluded, quote, "It is not yet clear whether the focus on hospitals during the early stage of the pandemic in Ireland distracted attention from other important settings, such as residential care facilities, including nursing homes," end quote. Next slide, please, Karina. Similar to other countries in Ireland, older people, including those in nursing homes, were viewed as being especially at risk of contracting the virus. In a government press release on the 4th of April, the Minister for Health declared, quote, "The nursing home sector cares for one of the most precious and vulnerable groups in our society. We must do everything we can to support them to help break the transmission of the virus. It is vital we leave nobody behind as we navigate our way out of this pandemic," end quote. Next slide. In the national broadcast media, the collective noun "the elderly" was almost exclusively used in reportage, commentary, and panel discussions concerning older adults and COVID-19. The closing item of a national radio news programme broadcast on the 24th of April 2020 presented a well-worn ageist trope, that of older people engaging in unconventional activities and, by implication, deviant behaviour for their chronological age. Prefacing a sampler of a Rolling Stones new record, the news anchor Anya Lawler remarked, quote, "And now, to cocooners, something especially for the shut-in over 70s. This is a short clip from the Rolling Stones' latest single, their first original song in more than a decade. And bear in mind, the band's collective age is a nearly whopping 305 years. So not bad for cocooning 70-year-olds," end quote. Next slide. So conclusions. The global pandemic has provided a new context within which older people were discursively constructed as universally vulnerable, and by inference, a homogeneous group. And there is a body of published evidence that shows how some well-worn ageist tropes have revealed themselves. In this regard, Lichtenstein writes that ageist rhetoric has been a dominant theme of pandemic control. Next slide. The practice of transferring patients from the acute hospitals to nursing homes as a means of maintaining surge capacity in hospitals, and a lack of preparedness on the part of nursing homes themselves to withstand the initial wave, appear to have been contributing contributing factors in the high incidence of the virus in nursing homes. And there is corresponding international evidence of a lack of preparedness for the impact of the virus on the part of residential care facilities. On the policies of appropriating residential care as part of the health system response to the pandemic in other countries, Liechtenstein writes, quote, "The architects of benevolent ageism failed to anticipate how sequestration exposed residents to COVID-19 in aged care settings, where they were concentrated and infected in large numbers." End quote. Next slide, please, Karina. So this paper presents a number of questions. Notwithstanding the dominant official entreaty to protect our most vulnerable, did the initial health system response actually protect? Did the response tacitly demonstrate that nursing home residents and the carers were less of a priority than other sections of the population in terms of managing the health resource? Does society consider older people as more expendable than younger people in the face of the pandemic? Did the health system response in Ireland, along with public discourses, betray a latent ageism? And the next slide, please, Karina. And I've left you with some references which we will provide. Thank you, Karina. Next slide, please. Now, I'm pleased to hand over to my colleague, Dr. Deirdre O'Donnell, who's going to speak on the topic of capturing new ways of working in the care of older people during the COVID-19 pandemic, results from a rapid exploration of emerging evidence. Thank you, Deirdre.
Thank you, Jared. Thanks for the introduction. Okay, so the review that I'm going to describe today was conducted as part of a wider applied partnership project, which was funded by the Irish Research Health Board called Eclectic. And that commenced in September 2019. Karina, do you want to move on to the next slide? Thanks. So the aim of the Eclectic Project was to describe or to develop a framework which will describe the key competencies for interprofessional collaboration within multidisciplinary teams who are coordinating and delivering care, integrated care with older people. So the project partners with an interprofessional subgroup of the integrated care programme for older people in Ireland. So last March, when the full implications of COVID-19 were being realised in Ireland, we entered a nationwide lockdown. And this resulted in a suspension of the qualitative data collection for the Eclectic Project. At that time, we were hearing anecdotally from our collaborators who are interprofessional healthcare workers delivering integrated care for older people, that they were experiencing huge changes in how they were working, particularly at the team level. It was becoming clear that interprofessional team working was essential to the continued delivery of services for older people, particularly those in the community settings. And there was huge flexibility required in terms of how teams were working. Particularly that move to telehealth, which has become a very dominant theme of the last 9 months. So while we were suspended from empirical data collection, we thought that maybe we could try and capture and synthesize some of this emerging evidence of these new ways of working as a response to the pandemic. And we wanted to particularly focus on the integration of care for older people. We wanted to see what we could learn about team working and particularly interprofessional collaborative team working in relation to the care of older people that could assist us with developing our competency framework. At this point, it would be important to acknowledge that the team involved for this review work included Dr. Aideen Leahay, who's a co-investigator for the Eclectic Project, as well as Marie O'Shea, who's the project manager. We also approached Diarmuid Stokes from UCD Library, who assisted us with the development of the systematic search strategy. Next slide, Karina. So what did we do? So we retrieved evidence from 3 sources. We used the Twitter advanced search function to retrieve tweets which mentioned new ways of working in relation to health and social care. So this was to provide a broad overview of how the changes to health and social care were being described in social media. For a more focused look at the changes that were occurring in relation to the care of older people, we conducted a systematic search of the Nexus UK database to retrieve newspaper articles that were describing responses during the initial period of the pandemic in Europe. And we employed 4 search strings, which allowed us to focus specifically on articles published in Europe that described the care of older people and that related to team working or interprofessional collaboration. So we searched the Twitter and the newspaper archives between the dates of the 1st of March to the 11th of May. So we really wanted to capture that very early initial phase of the response to the pandemic. And then finally, at the end of that, we conducted a workshop with members of the interprofessional working group of the Integrated Care Programme for Older People. There were 11 healthcare professionals represented in that working group. And the purpose of this was to substantiate and confirm what was emerging from the Twitter and newspaper searches, and I suppose to transpose those findings into what was happening on the ground in locally in Ireland. So the next slide then, please, Karina. So just in terms of what we found, so we retrieved 317 tweets relating to 6 new ways of working in health and social care during the initial phase of the pandemic, and that was kind of that broader and broader perspective. And then we had 34 newspaper articles that were specifically addressing the health system response in relation to health and social care of older people. So combining those two sources, I suppose there's 4 major clusters of data, I suppose. The first one describes role expansion, and I suppose there was a lot of discussion in the articles and in the Twitter of the necessity to compensate across disciplinary roles within the teams. And this was particularly where there was redeployment of healthcare staff to other areas within the health system. There was sharing of duties, an extended scope of practice, and a rapid acquisition of new skills and tasks within these teams. The old hierarchical structures were disappearing. There was a lot more evidence of lateral decision making and decision making that was happening quite rapidly in response to the changing circumstances. All of this, particularly the role expansion and greater role awareness, enhanced trust within the teams, because essentially they had to rely on each other, particularly for information regarding assessment. The next kind of major area was around innovation and communication. So we have all, I suppose, had to rapidly innovate in all of our lives the last 9 months in terms of the use of online technologies. And this is also present in health system responses. So the use of online and virtual technologies, and particularly telehealth, to provide care and information to families and patients was well described in Twitter and in the newspaper articles. The newspaper articles focused a lot on the use of this technology to continue to provide social and emotional support to older people and their families, particularly within community settings, and particularly those that were maybe experiencing some level of social isolation as a result of the necessity to physically distance. There was also descriptions of the use of virtual forums for staff training and education, for sharing information and for care planning. There was descriptions of team huddles being conducted online and team meetings being conducted online. There was the use of online technologies for the rapid assimilation and implementation of evolving practice guidelines. So as evidence was emerging in terms of how to manage the virus, there was guidelines and practice standards that were being developed quite rapidly, and they had to be assimilated rapidly on the ground, and technology was a huge enabler of that. There was also discussion of the environmental restructuring, and that really referred to the physical infrastructure and spaces where care was being delivered, particularly in acute and residential settings, where we had the designation of COVID wards, green and red zones, etc. There was also new team compositions representing a much greater level of integration across care settings, where we had team members, for example, from the acute settings moving into support residential care settings. The other theme was generally around enablement. And I think one of the key findings for us in terms of the competency development, or the framework for competencies, was the sense that the teams felt very empowered at a local level to implement changes at a local level quite rapidly. So there was a lot of that lateral decision making that was happening within the teams, which is quite interesting. There was there was the virtual forums and the online forums for knowledge and skills acquisition as well, which was very interesting, and the sharing of organizational knowledge as well across settings. For that kind of it's an interesting phenomenon in terms of the integration of care. So the next slide then, Karina. So then we took those findings to this working group of healthcare professionals. So that represented healthcare professionals from across the spectrum of disciplines that are integrating care for older people in the community. And they confirmed really much of what we were finding from the Twitter and the newspaper articles. They definitely spoke about that common goal, particularly in those first phases of the pandemic, being a unifier for the teams. and that sense of being empowered at a local level of lateral decision making, and that the old hierarchical structures for decision making were disappearing. However, even at that early stage, and that was in June, last June, there were concerns being expressed by those disciplines in the working group. They talked about the gaps in service provision that were emerging, and this was particularly in relation to withdrawal of services within the community settings and the redeployment of staff to testing sites. There was also concerns raised about the impact at that time on the psychological well-being of staff, of health and social care staff. And there's just a reference there in the yellow box to the journal article, or the journal article that was published on this study as well. So Karina, do you want to go to the next slide? So in conclusion then, and where are we now and what's next? So we're now engaging with remote data collection to complete phase 2 of the study. We're continuing to collect qualitative data from members of 2 multidisciplinary care teams integrating care with older people in 2 sites. So there's 1 rural site and 1 urban site in Ireland. So we're adopting a prospective qualitative lens, essentially, following these teams from before the pandemic and tracking their journey through the pandemic, noting how they're adapting in response to COVID-19. So that data analysis is ongoing. We're kind of iteratively collecting the data and analysing as we're going along. And I suppose one of the key things that's really coming out from me from the data is this idea of sustainability. And an important question that we need to all consider is, what innovations do we want to sustain that have been introduced in the last 9 months, and how are we going to do that? The rapid review of emerging evidence was captured at a very specific point in the journey, particularly in Europe, and that's that early phase of the journey. And I think what we're now hearing in the latter phases is staff, we're hearing about staff who are exhausted, who are burnt out and frustrated at the redeployment, particularly, and in gaps in service provision. So while that initial energy that we were able to capture in that first wave was almost positive in terms of teams being galvanized to focus on a common enemy, and that had a really positive impact on how teams were working and how they were collaborating, that energy is definitely waning now and the cracks are appearing. There's particular concern around redeployment of staff from community care teams, and this has led to gaps in service provision and a strain on the teams. And we can see that safeguarding has been a particular concern, where social workers have been redeployed or where they have been restricted in their access to older people in their homes. However, I do want to finish on a positive note, because it's November now and maybe we're all tired and even maybe a bit burnt out. So what we saw from the emerging evidence in the initial phase of the pandemic was hugely encouraging from a health systems perspective. We have evidence now that the Irish health system, and perhaps health systems more broadly, are not some slow-moving glacier, or at least they don't have to be. We saw evidence of agility in the system, flexibility in terms of new ways of working, and most importantly, I would say, a huge amount of creativity and collegiality among health and social care teams, who are working with those that are perhaps most adversely affected by this pandemic, as was so eloquently described by Gerard. This is a hugely positive, and I suppose from standing on the outside from an academic point of view and from a health systems perspective, I also find it hugely inspiring. So thank you. I'll hand over to Aoife now, who's going to talk about staff experiences of innovative teamwork during COVID-19.
Great, thank you very much, Deirdre. Hi everyone, it's a pleasure to present this morning during this webinar. And today I'm going to talk about staff experience of innovative teamwork during the COVID-19 pandemic response. So next slide, please, Karina. So to build on what Gerard and Deirdre have kind of already alluded to, our first case of COVID in Ireland was on February 29th earlier this year. And having observed the impact of COVID on other health systems, I suppose there's an awareness of the fact that Ireland was in a particularly vulnerable position given the low number of critical care beds in the health system. Ireland's critical care capacity is among the lowest in the OECD countries, and actually our public health hospitals have been operating close to or at capacity for a number of years. So initially there was a recognition of the scale of the response that would be required to support the health system without overwhelming it in response to COVID. And this was very much what we observed. There has been an extraordinary and collaborative response, as Deirdre has mentioned, from the health service in terms of ensuring services, continuity in services, but also that services were not overwhelmed in response to the pandemic. So very early, healthcare workers were sharing stories of these innovations, of these examples of team working from their experiences via media and social media channels. So next slide, please, Karina. So while we've done a good bit of work in our team in UCD understanding experiences of team working and collaboration in, I suppose, normal healthcare circumstances, there's been also a call to understand the impact on healthcare teams and how they operate effectively in these extraordinary circumstances. So with this in mind, we posed 2 research questions. So the first, what were the enablers, what were the mechanisms and enablers of innovative quality and safety-based practice during COVID response? And how can we harness and learn from staff experiences to inform ongoing reform and improvement of healthcare planning and delivery? So next slide, please. So the aims of this were to understand staff experiences of healthcare delivery during the pandemic, to explore the perceptions, motivations, and attitudes of staff to the adaptation of healthcare delivery and services, and to learn from best practices to inform ongoing and future improvement of healthcare services. So learning from best practices in order to identify what QI skills, what quality improvement skills and non-technical skills were utilised and how we can springboard that back into the system very quickly for rapid implementation and learning from good practices. Next slide there, please, Karina. So to do this, we availed of a mixed methods approach. So we kind of had 3 threads to this approach. First was to collect narratives of the response to the COVID pandemic, so stories that were being shared online. And these are being analysed on an ongoing basis using a thematic approach. The next was to conduct an online survey, which was largely quantitative in nature using some psychometrically valid scales, looking at collective leadership and staff engagement. So collective leadership, for those that may not be familiar with the concept, is the idea of leadership as a team-based character rather than individual characteristic. So collective leadership means individuals on the teams sharing in roles and responsibilities where they have the expertise and motivation to do so. So a subset of people who participated in the online survey could also volunteer to take part in an interview with a member of the research team. So we are interviewing on an ongoing basis a subset of those participants to kind of get a more in-depth understanding of experiences of team working and innovative practice and leadership during the pandemic response. Next slide, please. So we, in order to minimize, I suppose, the burden on healthcare staff during the pandemic, we use a snowball approach and recruited via social media channels. So we use our project social media accounts to encourage the sharing of stories. And we also use the Twitter hashtag that was widely used at the time by the Irish National Health Service and as our health service, amongst others, to help us identify stories. And we also asked leaders in the health service to record very brief videos for us to help explain what we were trying to do and to attract and encourage others to share their stories with us. As you can see, we use a few infographics to try and engage people and attract attention to what we were trying to do as well. Next slide, please. So we knew there was a huge range of stories to draw on. So we knew it would be very important to, I suppose, narrow the scope of our investigation, be very clear on what our inclusion criteria would be. So collaboratively with our health service colleagues, we decided on the following, that we'd focus on stories that were detailing the experiences of a healthcare team or healthcare delivered by a team that were focused on changes in service provision or changes to ensure the continuous delivery of services, and with a focus on one or more of the following thematic areas: innovation and initiatives, teamwork and leadership, quality improvement, and or patient-centered care. Next slide, please. So these criteria kind of helped inform what was included in our analysis. So we used social media, predominantly Twitter, using various hashtags to identify potentially relevant stories during a 4-month period from March. So as you can see, there's a lot of potential tweets, potentially relevant initially. So we had to go through a process of removing duplicates and removing those that didn't meet the criteria. And going through this process left a potentially relevant Twitter story data set of 89. We also harnessed stories that were already publicly shared by the National Health Service Health Matters magazine. So again, applying the same criteria to these stories and identifying stories that were potentially relevant. So this left us with a potential story data set of 113 stories. And with our health service partners, we engaged in a ranking exercise to prioritise the stories that we'd follow up for more information and that we would analyse. And the aim of this was kind of to get a cross-section of stories across the country and across different types of health services and different types of teams and different types of innovation as well. Just try and get it real of what's going on at that moment. Okay, next slide, please. So moving to some preliminary findings from this work. Next slide, please. Firstly, the online survey, I'll just touch on very briefly as the data analysis is ongoing. But for our collective leadership scale, and as I mentioned, this is the degree to which leadership roles and responsibilities are shared across all team members. There was a strong sense that collective leadership was being practiced, with high levels of collective leadership being reported, particularly in the domains of problem solving and support for colleagues. So among the items that would have been responded to in this survey would be things like degree of involvement in deciding on the best course of action for the team when problems arise. So again, it's really harnessing that collaborative and collective approach to identifying and solving problems when they emerge. Regarding support for colleagues, this is very much in the area of supporting team members that might need help. So high levels of reporting, engaging in role blurring behaviours, so people supporting colleagues where they have the expertise and motivation and skills and confidence to do so. Unsurprisingly, we have high levels of staff engagement also reported, and dedication was notably the highest, and this is something that's kind of reflected in our qualitative data as well. So as I mentioned, interviews with a subset of respondents are ongoing, so we hope to tease into these findings in a bit more detail through collecting qualitative data. Okay, next slide, please. So moving to the patterns evident in the narratives, one of the things we've seen very quickly is a rapid shift from a traditionally top-down approach to service redesign to a more bottom-up, grounded approach, whereby it's the teams themselves that are being given the autonomy and the permission to make changes and quickly implement new ideas and solutions. So often we're being told that these are ideas that they've been kicking around for quite some time, but this is the first time they felt that, well, they've had the impetus, but also the permission to actually make the changes that they see that need to be made. So a nice quote from one participant: "Creating the space to pause and reflect is key, and our shared purpose unites us." So again, it's, as Deirdre mentioned, it's teams being galvanized around this shared purpose that's unlike anything they've experienced before, this common goal. And we're seeing people report often the first experience, what they describe as true team working. So clear working across professional boundaries in a collaborative way, and recognizing the expertise and the skill set of other professionals that where they didn't maybe have that knowledge of what others could bring to the table previously. So it's been an eye-opening experience for many people who haven't worked in real teams before and have been more, I suppose, more independent in how they work. Another common thread across many of the narratives is the person-centered approach adopted in many, if not all, of these initiatives. There's a real effort to maintain that connection between healthcare staff and patients and families. So this is a nice quote from one example. "Being in hospital can be stressful for patients and their families. We've put up a what matters to you chart in a patient's room. It captures personal information about the patient, so we really know a little bit more about them and what really matters." So it's efforts to kind of maintain that connection despite what might be layers of PPE at the moment. Next slide, please. So we're also seeing collaboration across teams and across organizations that have no tradition or history of working together. So we're seeing of integrated care being designed and implemented very rapidly and very soon. We're seeing healthcare professionals engaging in role blurring behaviour. So again, supporting others who may need that support. And as Deirdre mentioned, we're also seeing, that not everything is positive at the moment. There is an effect of redeployment. People sometimes feel that their skills aren't being utilised to the full extent. And one participant reported feeling a bit at sea, so a bit lost in all the change that was happening. Despite this, there has been a strong sense of pride coming from the strong community and national support of healthcare workers during this time. And in the early stages of the pandemic, this was really helping to promote resilience among healthcare staff. Unquote, "It's been truly heartwarming to see all the local support." But as Deirdre mentioned, as the pandemic goes into the 8th, 9th, 10th months, there's a cumulative effect on healthcare workers now and potentially dropping off of that kind of support where people are getting a bit fed up and tired as well. So collecting data at the moment will help us look at the longitudinal impact on healthcare staff and whether those experiences have been sustained over time or what's happening on the ground at the moment. Next slide, please. So in terms of the impact, we're hoping through this research, we'll be able to support the continued engagement of staff in helping to deliver efficient, effective and patient-centred healthcare. To continue the collaborative and collective leadership approaches that have been, I suppose, organically developed through the response to this pandemic. To share learning internationally from our health system, and considering the way we've managed to successfully reconfigure services to avoid overwhelming the health system. And as I mentioned, to springboard this learning back into the health system as quickly as possible through links with our partners to inform training materials in terms of embedding and sustaining new ways of working and maintaining these collaborative approaches over time. Next slide, please. So finally, I just wanted to thank Zanira Khurshid and Sabrina Anjar, who've led on this work. And just to mention that I'm presenting today on behalf of the wider co-lead team at UCD. And next slide, thank you very much for your attention today. I'll pass back to Jared.
Thank you. Thank you, Aoife. And if you can allow me to be on video there, Karina, if possible, I think you have control there, not me. But in any event, I'll let you do that, Karina. I don't seem to be okay. You need to make me host, I think, so I can do it. Anyway, first of all, Aoife, thank you for your paper. Deirdre, thank you for your paper. And just maybe before I start, because I see there is a question in there from John Gilmore. John, we'll come back to your question. I gave a brief response on the chat there. There you go. So I just wanted to just kind of mention, you'll have noticed in my own presentation, I had several images of older people. I was using images of older people, as it were, rather than having long passages of text in the slides. And I confess, and I acknowledge, in fact, that the slide images of older people that I use may themselves constitute a discourse. So I'm very, very mindful of that. And as we know, discourses are not just they're not just words and texts. They're also images and many other things as well. So I just wanted to mention that. Also, I think maybe we might take John's first question in the Q&A there, John. Thank you very much. You raised a question about whether whether we feel as panelists that there needs to be a stronger nursing voices underpinned by nursing knowledge and philosophy within the health system, and how might an approach grounded in nursing philosophy lead to different, better outcomes. And then you raised a question about role expansion, which I think I'll address in a moment. I replied very briefly, John, and others in the webinar may have seen my brief reply. I think your question does imply that nurses' voices were not strong, and I think, as I said, this was evident, I think, in the daily and weekly briefings in the national broadcast media by the Department of Health and the public health experts. I think there is a senior nurse in the department who actually did speak on the matter of nursing homes. So that may be in itself remarkable, and on social care as well. I think if my other colleagues want to come in, but I think nurses can be a voice for the voiceless more than advocating for themselves. I think that's maybe my response. And as I've tried to demonstrate in my presentation, I think the voiceless were the older people, particularly older nursing home residents. So I think if nurses have to be a voice, I think that's where their voice needs to be heard, I think, for the voiceless. On the matter of role expansion, yes, I did suggest in my response to you, John, that there is a risk that nurses may inadvertently appropriate roles that are outside the scope of practice. And I think scope of practice is key in that regard. And as I hinted in my response to you on the chat, we've done some work in clinical leadership, and one of the things that we found was that nurses do engage in this compensatory behaviors and picking up the pieces from all other disciplines, and that's a really historical there are historical precedents for that, going right back to when the ladies superintendent or the matron was responsible for the hospital household and all that went with that. And I don't mean that in terms of domestic chores and that, but I'm simply, or healthcare assistant or anything like that. I'm simply meaning that the nurse, or the lady superintendent had sort of responsibility for everything else that the medical team didn't do, as it were. And that's why I'm suggesting that. So thank you, John. That's my best call on that one. I don't know if anybody else wants to there's Eileen Furling wants to ask a question there of Aoife. Maybe I don't know, Karina, if we can let Eileen speak, but maybe if she wants to type out a question there.
Yeah, I'll just allow Eileen if she'd like to speak.
Thanks. Go ahead, Eileen.
Good morning, everybody. Thank you, and thank you very much, Jared and Deirdre and Aoife, and thank you to the panel. Sorry, I started a question and I realised I didn't finish it. Aoife, it was more really interesting, all speakers, thank you. It was really in relation to, you talked about the true teamwork and from the narratives, Aoife, and then the role blurring. I'm just thinking, is there, and I know there is some contradictory issue there, but can you just comment on that, Aoife, that in some ways they were saying the teamwork and all the professionals working together was evident, and yet then there was role blurring happening.
Absolutely. I think this is a really good point, Eileen, because it's very much, a very subjective understanding of what true teamwork is. And this is something that we want to unpick more in the narratives in terms of who's telling us these things. So, for example, the true teamwork comment came from medical professional, and the role blurring discussion came from nursing staff predominantly. So true teamwork, people may understand what that looks like or what that is in different ways. So I think we want to understand people's interpretation and understanding of that. But also some people described, feeling covered and feeling supported by other team members who were helping to cover them as an example of true teamwork. So some people define that role blurring behavior on the part of others as indicative of being part of a team.
Okay, thank you. Yeah, and it's an interest, particularly from a nursing perspective in relation to the leadership roles that they undertake. Thank you, Aoife.
Thank you for your questions, Eileen, and your response, and thank you, Aoife, for your response. I don't know if Deirdre wants to respond in that, because I was very mindful that there were sort of parallels between Deirdre, your presentation, and Aoife's around. I think Aoife spoke about top down and bottom up, and you spoke about lateral versus hierarchical. I think it was the same thing, really, in different ways of expressing it. Do you want to comment yourself, Deirdre, on Eileen's or indeed on John's?
Yeah, just about the role expansion side of things. What we were hearing, and again, we were focusing predominantly on integrated care teams, who are in Ireland anyway, a kind of a new enough innovation in the health system. Particularly in the kind of, there's a pilot program at the moment for integrated care teams for older people. And what we were seeing was a lot of compensation because of redeployment. So they had lost disciplines from their team because they were redeployed into testing. And so what they essentially had to rely on each other to fill in the gaps. So there was definitely incidences where they spoke about extending their scope of practice, moving in, but it was mostly where I saw it was, or where they were described it mostly, is in relation to assessment and sharing information around assessment, and relying on other disciplines to for their own assessment processes as well, which was interesting. Interesting enough, in none of the teams that we've looked at so far, the nursing staff have remained integral to the team, so they haven't been redeployed. It's been more relation to the allied health staff as well, so that have been moved out. But I suppose that's kind of my main thing around and I think there also has been, as you say, the top down or bottom up, but what they described was much more of a lateral approach in terms of, because they were a predefined team. They found that there was a lot more, they were more kind of empowered locally within their own team working to implement changes. And there definitely was a move towards more lateral decision making in those teams. So.
Thank you, Deirdre. And just to say, if anybody says I have a question, you could just type it in the Q&A, and we'll invite you to come in on the vocal and or the video. But just maybe I might pick up, Deirdre, about that notion of empowerment, because empowerment implies that, we tend to say, oh, you empower somebody, but ultimately people empower themselves. So that's really what, conceptually what empowerment means. It means is that you assume the power to make decisions and to engage in what actions you want. My question really is there a sense in which, when they felt empowered, I suppose the question might be, did they feel that they empowered themselves? Maybe it's a kind of a maybe it's the wrong question to ask.
No, I understand. No, I think it's actually something that Aoife mentioned there about things that were kicking around for a while that were taking a long time to push through the system. All of a sudden, the doors opened. So there was a lot more energy around. There was a lot more doors open for them to do things that they knew now had to be done and were trying to get done for a while beforehand. So there was funding available for things that wasn't available prior, and there was also a much more kind of a sense of we just got to get this done, and that they're galvanized towards this kind of common purpose. So from that perspective, it was positive, I think, and they took advantage of that in terms of being able to implement changes that they needed to happen. So,
thank you. And I see. Sorry, Aoife, go ahead. Yep.
Maybe come in there to add to that. I think there's been a sense of kind of learned helplessness in the health service for a long time. They've been trying to make changes and things haven't happened, and the sense of just giving up and that it's not possible for me to make change anymore. But what we're seeing is people seeing the results of their efforts happen very quickly, and that being very motivating and empowering, and giving them the sense that they can affect change in health service.
Yeah. Thank you, Aoife. Now we have a question from Irma Rodriguez. Good morning, Irma, or maybe it's a different time zone for you. But you asked the question: in what ways were the roles of nurses expanded? And you're very welcome to put on your speaker if you want to discuss this as well with the discussants. So maybe Deirdre, I think. Was it you who mentioned role expansion?
Yeah.
Yes. And again, Aoife, I think they're parallel. So if you want to take that one first.
So the role expansion that we're seeing from nursing particularly is around the sharing information for assessment. So there's a lot more of that collaboration, pooling together individual, because they were trying to reduce their contact and not have an older person living in the community having too many healthcare professionals coming in to assess them and to deliver interventions. They tried to unify a little bit and to help each other out essentially. So if a nurse was going to go visit an older person to do an assessment or to deliver intervention, they may also take something or undertake something on behalf of another discipline in the team, but they were all doing this. So similarly, a nurse could ask a physio who was going in to do something as well and to report back on the patient status in relation to a nursing intervention, nursing assessment. So it was more that kind of team approach to and kind of joined up purpose and also, sorry, there was a lot more telehealth going on. So they were undertaking phone conversations in order to, so it's almost a triage or a pre-assessment conversation. And again, they were pooling in what kind of information needed to be extracted or gotten from the patient and what information needed to be delivered from the patient. And they were trying to do that in a much more interdisciplinary, interprofessional way.
Thank you, Deirdre. And Irma, if you want to respond, you're very welcome to put on your mic and respond. But in the meantime, while you're thinking about that, perhaps and thank you for that very helpful response, Deirdre. In the meantime, I think, when we talk about role expansion, there is the risk, as Aoife referenced in one of her later slides, of role blurring. And I think, role expansion the role blurring is always the risk of role expansion. And that's why I was keen to, in responding to John Gilmore's question, mention, scope of practice. But is there anything else you want to respond to Irma's question, Aoife, in relation to role blurring, maybe in that context?
Just to say that in terms of additional roles being performed by nurses, that's not something we've had a chance to explore yet. So that finding came out from the quantitative survey, so we know it's happening. We haven't had a chance to tease in and dig into that yet.
Okay, very good. Irma, thank you very much for your question. And if you want to sort of respond or come back, you're more than welcome to switch on your mic and do so.
Can I just add, wanted to add something, just something occurred to me there, which I think it's interesting. What I suppose, yes, there's role expansion, but there was also what we found much greater role awareness So much greater awareness of what other disciplines contribute.
Okay.
And I thought that was interesting in terms of maybe counteracting a little bit of the blurring bit. It's a lot more of an understanding of what each discipline contributes to the care, the holistic care of an older person, which I think is a really interesting innovation or interesting outcome of this, and I think something that is really important for strong team working and interprofessional collaboration and greater awareness of what each person does.
I echo that as well, Deirdre. I think there's definitely a recognition of the skill set, the specific skill set that was being brought to the table when teams are coming together to redesign services, and an awareness that potentially wasn't there before across professions. So
I think that definitely supports that lateral decision making as well.
Thank you both. Yeah, no, that has always been something of the creed of care of nurses, you know, of what we do, and nobody recognizes the range and scope of what we do and our contribution to care. And sometimes it's often seen as, well, you know, and sometimes nurses themselves are unable to sort of articulate it. And it seems to me that from both of your studies, what you're really saying is that in some ways, you know, the visibility of what nurses do and their contribution to care became more visible in their responses and in their actions and in their interactions with other disciplines than anything you might write about or say or sort of plead about. Thank you, Rosie Stenhouse, for your very kind comments, and we appreciate your comments. But that's my response to that. I think you know it's in and through the way in which they responded, and particularly in the ways in which the nurses actually acted out their professional role and the scope of their practice role, that actually it became more visible. So maybe John Gilmore's original question about the voice of nurses, I think the voices may have been visible in their actions and in the ways in which they responded, more than what they might have said about their roles and so forth. Karina, I'm mindful that it's 3 minutes to go, and I think I'm mindful that we might begin to close the webinar now in the next few moments. But I would invite anybody else to, if they want to come into it with a question there, just raise a hand or put up a thing. Okay, so we'll take that as a. I'm just checking my little screen here. We'll take that as a no. Now, am I seeing? Sorry, Karina, I've lost the screen there. There we go. Thank you. Okay, so as we bring the webinar to a close, this third webinar in the Universities 21 Nursing and Midwifery Group, a webinar series for 2021. We're delighted that you were able to join us. We had a good attendance this morning, and I want to thank Julia for her introduction earlier on. I want to thank Karina Greenwood, who's over there in Birmingham, keeping us all in the straight and narrow and making sure that this particular webinar worked seamlessly, as I believe it did, Karina. So hats off to you, and thank you very much. I want to especially thank my nursing and midwifery health sciences group colleagues for their participation as well, and in their earlier webinars for this year. And let's hope that in 2021 our webinar series will maybe be able to talk about, maybe, dare I say it, impact of vaccines and uptake of vaccines and reopening of societies and so forth. That's what we all wish for. But in closing, in the last moment or two, I want to particularly thank Dr. Deirdre O'Donnell and Dr. Aoife de Bruin for their respective contributions. And I want to thank you all for your nice comments as they're coming through just now. Yep. Okay, I'm just scanning them there. Thank you all very much. Is there anything else we need to say in the last moment of the webinar?
No, I think that's it, Gerard. Just to say, as you've mentioned, the recording will be available later on today on the website, and so please share that amongst your colleagues. But thanks for attending.
Of course. Thank you very much, Karina, and thank you all for attending, and have a good day. Thank you.
Thank you.
Bye-bye. Bye-bye.